Okay, that's better. Good morning. My name is Neil Ferguson from the University of Toronto. I'm delighted to be co-chairing this session with Luigi Camperotto from Guy's and St Thomas's in London. And we have an action-packed session today on ARDS management, which we'll keep tight and get started with no further ado. And I'm very pleased to introduce our first speaker, Professor Carolyn Calfee from the University of California, San Francisco. And she's going to talk to us about, do new criteria for ARDS make much difference? Welcome, Carolyn.
Thank you so much. Thanks to the organizers for the invitation to be here today. These are my disclosures, none of which are relevant to what I'll be talking about today. So, as I think we all are probably familiar with, ARDS has a long history of evolving definitions, beginning with the first initial report of ARDS, a 12-patient case series in The Lancet in 1967, the classic Ashbaugh, Bigelow, Petty, and Levine paper. The first quantitative definition of ARDS was in 1988 by Murray and colleagues with the 4-point acute lung injury score, followed by the North American Consensus Conference, which is what I learned when I was a resident, published in 1994, including the term acute lung injury. Then, of course, in 2012, we had the Berlin definition, which we'll talk a little bit more about in a few moments. That's been what we've used for most of the past decade. But there have been other important proposed modifications, including the pediatric ARDS definition, which included non-intubated patients in unilateral infiltrates, and the Riviello Blue Journal paper in 2016, the so-called Kigali modification for under-resourced settings, including ultrasound and oxygen saturation. And while we're going to talk today about new definitions of ARDS, I want to point out that we've had important successful clinical trials that essentially used the North American European consensus definition / the Berlin definition that have really changed our practice in ARDS, including the low tidal volume trial in the New England Journal in 2000, the FACT trial of fluid conservative therapy, and the ProSiva trial of proning, all of which required intubated ARDS. Now, of course, we have the Berlin definition that we've been using for quite some time, and I'm not going to go through this in detail because I think we're all very familiar with it, but just to emphasize that, again, it required bilateral opacities and mechanical ventilation with a PEEP of at least 5. So what is the new global definition of ARDS and what are its practical implications? So what really motivated the changes since the 2012 Berlin definition? Well, first, we had the increasing use of high-flow nasal oxygen for acute hypoxemic respiratory failure that we all saw really beginning with the FRAT trial in 2015, but really exploding during the COVID pandemic. We had the recognition that the SF ratio is a reliable surrogate for the PF ratio. Well, and I know Dr. Fujii is going to talk more about this question in a little while, and we'll talk more about it momentarily as well. Then we had the recognition that, of course, ARDS does not occur when a patient has a mechanical ventilator next to them, and so how do we manage in resource-limited settings? And then how do we think about this issue of unilateral versus bilateral infiltrates? So this is what motivated the so-called new global definition of ARDS, led by Michael Mathey, Lorraine Ware, Taylor Thompson, and colleagues, and published last year in the Blue Journal. This is images of the folks that contributed, and really was a global definition that included clinicians from low and middle income countries as well as from North America and Europe, included patient advocates, methodologists, community practitioners, respiratory therapists, and a very diverse set of contributors. The committee initially had a 100% consensus that the Berlin definition of ARDS needed to be updated, and then achieved consensus on new recommendations in 6 meetings. And there was input solicited from members of 21 critical care societies, but without a request for a formal endorsement. And here are the primary recommendations of the global definition of ARDS. First, that we retain the conceptual model from the Berlin definition with minor modifications, including the requirement for bilateral radiographic opacities. Second, that we expand the Berlin definition to include non-intubated ARDS with either non-invasive ventilation or high-flow nasal oxygen with a minimum flow of 30 liters per minute. Next, that we add the SpO2 to FiO2 ratio as an alternative to the PaO2 to FiO2 ratio for the oxygenation criteria. that we allow the use of ultrasound with a well-trained operator to diagnose bilateral opacities, especially in resource-limited settings. And finally, that we apply the Kigali definition for ARDS in resource-limited settings, including the SF ratio, and not require a minimum flow rate of oxygen or end expiratory pressure in that setting. All right, so let's take each of the major changes in turn. First of all, what motivated this inclusion of high-flow nasal oxygen? Well, as I mentioned, the Florally trial really changed practice when it came out in 2015 from Fratt and colleagues. And then, of course, as we all experienced, just the explosion of the use of high-flow nasal cannula during the COVID pandemic for what is essentially the same biologic process of acute lung injury. I think we're all quite familiar with the mechanics of high-flow nasal cannula, but just to remind us that, of course, this can be delivered at flow rates from 10 to 60 liters, provides a little bit of PEEP, and does increase carbon dioxide excretion, i.e. decreasing the dead space, as well as reducing the work of breathing. So what are the pros and cons of including this in the ARDS definition? Well, in terms of advantages, it helps us focus on patients that require high levels of oxygen and low levels of PEEP, regardless of the presence of an endotracheal tube, and one person's decision to intubate at one time versus another. It accounts for the evolution of clinical practice and facilitates enrolling patients in trials at an earlier stage, and we're already seeing that impact how clinical trials are being designed. Endpoints of trials can include progression to intubation, and of course it facilitates studies of early ARDS and the natural history of the syndrome. But it's not without its challenges. It's challenging to estimate FiO2 accurately, though I note that this was in fact done in the Fratt trial and others. The cutoff of 30 liters was relatively empiric. Is that optimal? I think that will be certainly discussed and hopefully studied over time. This approach may include patients with better clinical outcomes than the Berlin definition, and it still doesn't take into account resource-limited settings where high-flow nasal oxygen is not available. All right, what else has changed? Well, the recognition that the SF ratio is a pretty reliable surrogate for the PF ratio, beginning with studies out of Todd Rice's group in Vanderbilt in 2007 and progressing onward since then. I'm just going to show a little bit of data on this from Lorraine Ware's group, also at Vanderbilt, in which she studied MICU patients that were diagnosed by the PF ratio versus the SF ratio, and found that regardless of which of these was used, the baseline illness, including comorbidities and severity of illness, were similar, as were ventilator-free days, length of stay, and mortality. And in fact, the SF ratio correlated with mortality better than the PF in patients with severe disease. This also has pros and cons, right? So an advantage of using the SF ratio is that it's continuously available. It's highly sensitive for hypoxemia. It's easily interpretable. And of course, it's non-invasive, and there's no risk for procedural complications as compared to an arterial blood gas. And importantly, it's more readily available in resource-limited settings and outside the ICU. But there are some disadvantages as well. Measurement error is increased by poor perfusion, vasopressors, severe hypoxemia, or acidemia. We have the potential for misclassification of either the diagnosis or severity, and importantly, the potential for reduced accuracy in patients with darker skin pigmentation. And I suspect Dr. Fujii will talk about all of these issues in her talk. All right, so let's move on then to what else has changed since the Berlin definition. Well, I think we can all agree, as I said earlier, that it doesn't necessitate a ventilator at the patient's bedside for a patient to have a biological process consistent with ARDS. So what do we do with resource-limited settings where ventilators and high-flow nasal oxygen may not always be available? And Beth Riviello is really the major innovator in this area. She and her team in 2016 published the Kigali definition, cited in Kigali, Rwanda, in which they replaced the ABG with the SF ratio, chest x-ray with chest ultrasonography, and due to the scarcity of mechanical ventilators, did not require PEEP or a minimum oxygen support requirement. Now, while the hospital incidence of ARDS with this approach was pretty low at 4%, the mortality was high at 50%. And even in a highly resourced setting, subsequent studies suggested that the sensitivity and specificity of this approach were quite good. And so the committee thought that the formal adoption of the Kigali definition would allow for a better estimation of the true global burden of ARDS. Finally, the committee did spend a considerable amount of time on this question of unilateral versus bilateral chest opacities, in part because the LungSafe study and others identified similar mortality among patients with at least 2 quadrants involved, regardless of whether or not those were unilateral or bilateral opacities. But the group felt that this approach lacked some face validity because ARDS is really defined as a diffuse process, and felt that just because the mortality was the same, that did not really mean that the pathobiology is the same in unilateral versus bilateral disease. So this was what supported the committee's decision to continue to require bilateral infiltrates. The committee did, though, expand to include the use of ultrasound, which has good diagnostic accuracy for alveolar filling and consolidated lung in patients with ARDS, again in the hands of a well-trained operator, with the idea that bilateral worsening or loss of lung aeration defined by at least 3 B lines, shown in the image on the right, would qualify for the diagnosis. All right, so I'm not going to read through this whole table, but just really, again, to highlight the key differences from prior studies where we have ultrasound, we have the inclusion of non-intubated ARDS, high-flow nasal oxygen, and a separate definition for use in resource-limited settings, including the S to F ratio. So now this generates several different types of ARDS, and this is from the Blue Journal publication. On the top, you have a 68-year-old man with abdominal sepsis, septic shock, and acute hypoxemic respiratory failure who meets the typical Berlin definition because he's intubated, mechanically ventilated with a P to F ratio of less than 150. In the middle row, we have a patient who's 54 with breast cancer and COVID-19 pneumonia who's had worsening shortness of breath for 6 days on high-flow nasal oxygen at 40 liters with an SF ratio of 114. This patient would have been excluded from the prior Berlin definition of ARDS, but now included in the new global definition. And then finally, at the bottom, we have a 39-year-old with abdominal sepsis and gram-negative bacteremia in a small under-resourced hospital that lacks blood gases, radiography, or mechanical ventilation on supplemental oxygen by face mask with an SF of 142, and this is ARDS in a resource variable setting. Again, another new category. So in conclusion, has this new global definition changed my practice? I would say it hasn't really, because it was really generated in an attempt to better represent what we're all doing as intensive care unit clinicians. As I mentioned, this was particularly noticeable during COVID when we had scores of patients with the pathologic process that we think of as acute lung injury who are not mechanically ventilated. But I think it has a lot of potential to change how we define ARDS in epidemiologic studies and clinical trials. This is already happening, so new clinical trials are being designed that are including this new global definition, and I think this will be particularly true in resource-limited settings. And we really need more research on the impact of this changing definition, particularly in these areas. So in conclusion, what are the potential benefits of the global definition of ARDS? Hopefully it will stimulate both academia and industry to test therapies for ARDS at an earlier phase of acute lung injury when they may perhaps have more potential to be beneficial. We hope it will stimulate research to test the definition's reliability, feasibility, and validity, as well as enhance studies of clinical outcomes after ARDS by including patients at an earlier time point prior to intubation. As somebody who does a lot of biology-focused work, I hope that biology studies will be done at an earlier time point, helping us to understand early events in pathogenesis. And finally, hopefully this will stimulate more global research on pneumonia, sepsis, and ARDS. That's the end of my talk, and I'd be happy to take any questions. Thanks so much.
Thank you very much, Carolyn. This was a fantastic overview of the old and new definition of ARDS. We've got time for one question if you get the microphone.
Oh, Dr. Grasselli is jogging to the mic.
Yes.
Thanks, Carolyn. We had the discussion during the process of the ASICM guidelines, but don't you think that a new global definition of ARDS should be the effort of societies, like that it should be a result of an intersocietal process? Because now I think that we are a bit confused, because the Berlin definition to me it still remains the official definition of ARDS, and I understand that this is a way to overcome it, provided that we still need ARDS as an entity, but to me, I think that we should be more, if we want to be global, we should be also more, let's say, official.
I hear your point very much. So the question was, should we have a definition that's really endorsed and generated by multiple societies? And I think we really should. This was an attempt to generate that sort of energy and discussion. And that's why the leadership of this group sought input from multiple societies, but not endorsement, because it was thought that that would be a somewhat unwieldy process, particularly given the effort to make it global, right? It's one thing if it's just North American and European, but if we're really trying to make it global, how do you even include, all of the different societies that are relevant? But to your point, I totally agree, and I think that it remains to be seen whether this proposal will really be fully accepted by the global research community, or whether we'll need a more formal process that involves, I think, probably many different societies, right, if it's going to be a truly global definition, in order for people to adopt it and move forward.
One question. In terms of treatment point of view, does it really matter whether we'll stick to Berlin definition or new definition?
Okay,
yes.
That's a question, that's a talk in itself, isn't it?
Yeah, that's a really great point. And I would say, that's why I had that slide at the end. Has it changed my practice? It really hasn't, but I think it has the potential to change trials in the future. And I think that's when it will change practice. If we have a trial that shows, okay, when we include patients with 30 liters high flow, right, and that are non-intubated, and they all respond to X treatment, that's when I think it would actually change practice. But as of yet, no, it hasn't changed practice. I totally agree.
Fantastic. Thank you very much, Caroline. Now, before I introduce the next speaker, I would like to apologize to the gentleman front row, but we'll have more time later at the end, hopefully. But in the meantime, it's my pleasure to welcome to the podium Dr. Tomoko Fujii from GK University in Tokyo, Japan, who is going to answer the question, arterial PaO2 or SpO2? Thank you.
Thank you very much for the introduction. Good morning, everyone. I'm Tomoko Fujii from GK University Hospital in Tokyo, Japan. And I'm going to talk about arterial PaO2 or SpO2. Disclosures, nothing relevant to this talk. So I would like to start with some reflections to the history. In 1974, physicians aimed to compare patients' pulmonary dysfunctions with different levels of FiO2, and they started using PaO2 over FiO2 to measure it. Meanwhile, in the Far East Asia, where it is called Japan, Japanese bioengineer Dr. Takuo Aoyagi invented pulse oximetry in 1974, exactly in the same year, as a non-invasive method to measure blood oxygenation. And now it is called SpO2 as the fifth vital sign. And this enabled us to find ARDS cases that would otherwise be underdiagnosed, ensuring timely interventions. And since then, clinical trials in ARDS have adopted SF ratios, and more trials are using this measure to define any inclusion criteria or even outcomes, or some trials use SpO2 to impute missing PaO2. They use SpO2 if PaO2 values are not available. And this is the landmark validation study of measuring using SpO2 instead of PaO2. We want to know if using SpO2 is a valid method instead of PaO2. And this was published in CHEST in 2007 from ARDS Network, and they used more than 2,000 measurements to see the correlation of the two measures. And they've reported strong linear correlation and with the modest specificity and sensitivity if defined moderate ARDS. And many subsequent studies have generally confirmed this positive correlation. And as Professor Calfee showed us previously, we want to know if SpO2 over FiO2 is compatible. The group of patients defined with ARDS using SpO2 over FiO2 is compatible to those groups defined by PaO2 and FiO2. And this study used data from 362 patients with ARDS, and they reported that SpO2 over FiO2 to define ARDS captured a patient population with similar clinical characteristics and compatible outcomes as the standard PaO2-based definition. So we have S over F criteria adopted in a global ARDS definition, and now we can diagnose and categorize ARDS with a non-invasive method. But it should be noted that there are some limitations in using SpO2 and FiO2. This report was published very recently in February in Critical Care. They analyzed data from more than 700 patients with ARDS, and in this study, ARDS severity was misclassified by SpO2 and FiO2 in 33% of data points, and 84% of them were classified as more severe than defined by PaO2 and FiO2. So this is partly because, clearly oxyhemoglobin dissociation curve is nonlinear, as we can see here. And also, FiO2 changes were not correlated with proportional changes in SpO2. So this should be noted as the limitation of SpO2 and FiO2. Yes, and another thing we should be noted is that pulse oximeter is not accurate always. This data will be published in CHEST soon, and we obtained data from our ICU patients. We are located in the Far East Asia, so this is an East Asian data. And when we looked into the agreement between SpO2 and SaO2, we plotted SaO2 on the x-axis and the bias on the y-axis. And this plot clearly showed that some patients are, some SpO2 overestimates SaO2 and some SpO2 underestimate SaO2. And we explored the factors that affect the overestimation or underestimation and found that hypoxemia or chronic dialysis or physiologically CO hemoglobin can overestimate SaO2. And mechanical ventilation, inhaled nitric oxide, methemoglobinemia, sepsis, or with high-dose vasopressors, everything related to insufficient peripheral perfusion can be associated with the underestimation of SaO2. So when we think about patients with ARDS, the ARDS patients can have both of these features, so ARDS can attribute to both under or overestimation of SaO2. And what is more important is that this inaccuracy can increase the risk of death of the patients. We plotted the bias on the x-axis here and plotted the predicted hospital mortality on y-axis. So this graph showed both overestimation and underestimation of SaO2 are associated with the increased risk of hospital mortality. So, as a practical implications, arterial PaO2 or SpO2. So SpO2 is useful because it's non-invasive. We can monitor patient status continuously, and we can screen for ARDS even in resource-limited settings, including general wards, and we can detect early of hypoxemia in the ICU, and we can reduce unnecessary arterial blood gas sampling. This is good from the the viewpoint from Green ICU. But we still need PaO2 because it can be the only measure that to tell us the precise assessment of ARDS, which is not influenced by O2 dissociation curve, which is not influenced by peripheral perfusion. So SpO2 and FiO2 correlates well with PaO2 over FiO2, but it's not a perfect replacement. So PaO2 is still necessary for precise assessment. And I would like to touch on the skin pigmentation.
For 5 minutes?
A little bit, because I talked about it yesterday, so I didn't put it in this slides. But FDA, during the COVID pandemic, many studies have been published, warning that there is a difference in the pulse oximetry inaccuracy between different group of people with skin pigmentation. And FDA has released a draft of guidance for industries and manufacturers that recommend if they want to test or submit the data to the authority, they should have to include much more increased sample size of patients to ensure that various group of people are represented in the data. And also they recommend to measure the skin color and report it in the data set as well. And thank you very much. This is my talk.
Thank you very much. A nice talk. We have time for 1 or 2 questions from the floor, if anyone has one. While people are thinking about that, let me ask a quick question. Maybe I missed it, but I wasn't sure if you emphasized the point that for an SF ratio to be useful, one has to be keenly titrating your oxygen, and it's because if the saturations are 99 or 100%, then obviously the SF ratio isn't very helpful. So if you're implementing that, do you need to combine it with a strategy to wean FiO2 judiciously?
Yes, there is a good point, and it is the point that the study that reported the limitation of SF ratio wanted to emphasize that because the dissociation curve is not linear, and if we change FiO2 and it doesn't, reflect in the same proportion, the proportion of rate, SpO2 doesn't reflect at the same proportion of rate. So if we aim very high SpO2 in our patients, and it won't be reflected in the SF ratio, and we will not be applying the intervention that we're aiming for when we look at the SF ratio.
Thank you. I don't see other questions, so maybe we'll thank you very much, and we'll move on to our next speaker. And it's my pleasure to introduce Professor Giacomo Grasselli, who's coming to us from Policlinico in Milan, who's going to talk a little bit about same evidence, different recommendations, some new from guidelines from both sides of the Atlantic.
So thanks, Neil. Welcome, everybody. As you know, I had the honor to co-chair the process of the ESICM guidelines together with Luigi and Carolyn. Okay, sorry. These were my conflicts of interest. So in 2017, the ESICM and the ATS issued joint guidelines on the management of ARDS. And these were the 6 questions that were answered, low versus tidal versus high tidal volume and inspiratory pressures, prone positioning, high-frequency oscillatory ventilation, low versus high PEEP, recruitment, and ECMO. So in 2017, we did a joint guidelines. Then in 2023, we didn't. So the 2 societies decided to do different processes and issued different guidelines that have been published a few months apart in some major journals. I'm not going to comment on the political side of this. Let's stick on the differences in the methodology and in the recommendations. So first of all, the 2 guidelines had different aims. Okay, so the ESICM guidelines were intended to be a more global process. So we went through 9 domains. The first 2 were more narrative domains, And the first one, as you can see there, is definition, but it was, I don't know where it goes, but it was not intended to propose a new definition, just to discuss the limitations of the current body definition. But then the domain 3 to 9 were more clinical. In the end, we had 21 recommendations, and we issued specific recommendations for COVID-19. The ATS guidelines were intended to update the 2017 guidelines. So they decided to answer only 4 questions: corticosteroids, ECMO, neuromuscular blocking agents, and PEEP level, and ended up with 5 updated recommendations plus 4 recommendations retained from the previous guidelines. They did not give specific recommendations for COVID-19. One thing I forgot to tell you, that in the ESICM guidelines, we decided not to discuss pharmacological treatment of ARDS. So we did not discuss corticosteroids. We only discussed neuromuscular blocking agents who were considered as adjunct to mechanical ventilation. So this is a comparison of the methodology. So ATS guidelines had a lower number of authors. As we saw, lower number of PICO questions. We adopted a, I would say, quite strict grade methodology, and the ATS guidelines were probably more strict in adopting the evidence to decision framework for each PICO. In the ATS guidelines, all statements had 100% of consensus, while we had 2 rounds of voting, and we selected 80% as a threshold for consensus, for agreement. We both involved the patients. In the ATS guidelines, only 1 patient was involved, while in our process, in the ESICM process, we had 8 patient or family representatives who contributed significantly to the guidelines. We had meetings with them. They helped us to select the relevant outcomes, and they also reviewed the manuscript. And also, what may seem strange is that 7 authors, which is almost 1/3 of the authors of the ATS guidelines, were in common between the 2 processes. So this is the summary of findings. These recommendations are in agreement. So we agree on the need for low tidal volume with a strong recommendation in favor of prone positioning, strong recommendation against the use of recruitment maneuvers, of prolonged recruitment maneuvers. For low tidal volume, I just want to tell you a curiosity that in the end, in our guidelines, the meta-analysis was not statistically significant, like the diamond of the forest plot crossed the identity line, but in the end we decided to issue a strong recommendation in favor of low tidal volume based on expert opinion despite the lack of statistical significance. And this is the result of a fight with the methodologist. There is also another recommendation that we are in agreement, which is the one on VV ECMO. The difference is that the ATS issued a conditional recommendation in patients with for severe ARDS, while we had a strong recommendation, but still we are in agreement that VV ECMO is appropriate as a rescue treatment for refractory hypoxemia. There is disagreement on 2 important domains, neuromuscular blocking agents and PEEP. So for PEEP, ATS suggests the use of higher PEEP without lung recruitment as compared to lower PEEP in patients with moderate severe ARDS, while ESICM was unable to issue a recommendation for or against routine PEEP titration with a higher PPFI2 strategy versus a lower PPFI2 strategy. So there are methodological differences that can explain this. The ATS based its recommendation on 2 meta-analyses, one very recent and the one very famous published by Brill in JAMA. And the recommendation was focused on patients with moderate to severe ARDS, while ESICM wanted to issue a general recommendation for the total population of ARDS, irrespective of severity. And our recommendation was based on the meta-analysis of 3 trials that were the same that were included in the Brill meta-analysis. I remind you that the Brill meta-analysis had exactly the same result, but showed that in the subgroup of patients with PF ratio below 200, higher PIP was beneficial. We decided not to do this sensitivity analysis based on the severity of ARDS. And so in the entire population, the meta-analysis of the 3 trials, the EXPRESS, the LOVES, and the alveoli, is negative. Then neuromuscular blocking agents is probably the recommendation that generated more discussion. The PICO of the ATS was, should patients with ARDS receive neuromuscular blockade? It was based on 7 trials, 1,500 patients, and the outcome was 28-day mortality. Our PICO was different. It was thus the routine use of continuous infusion of neuromuscular blocking agents in patients in moderate to severe ARDS reduced mortality. The primary analysis was based only on 2 trials, the 2 trials published in the New England Journal of Medicine, so the Accuracies trial and the ROSE study. Still 1,300 patients, and the outcome was 90-day mortality. So these are 2 different processes, and these are the recommendations. So the ATS said we suggest using neuromuscular blockers in patients with early and severe ARDS, while we said we recommend against the routine use of continuous infusion of an MBA. And I want to highlight this, because these 2 recommendations are not so much in disagreement. I mean, if you stick to we suggest or we recommend against, of course they disagree, but then if you read between the lines, we all know that if you have to take care of a patient with PF ratio below 100 and maybe a very low compliance, then you cannot manage this patient without neuromuscular blocking agents. We were just pointing out that we do not suggest, or better we recommend, against the use of routinely using neuromuscular blocking agents in every patient with ARDS by continuous infusion. So it's an apparent disagreement, but in principle we agree. After the publication of the guidelines, intensive care medicine published 3 editorials. One was written by myself, Luigi, and Carolyn. The other one represents the perspective of the ATS authors. And the third one was published by Luciano Gattinoni. So which are the reasons for disagreement? Well, first of all, as I tried to show, methodological differences. So the processes had different goals. The exact formulation of PICO questions was different. The evidence to the decision framework was not applied in the same way. For example, this explains the conditional recommendation for ECMO in the ATS guidelines, literature selection, interpretation of the results, assessment of the certainty of evidence were sometimes different, and of course also the outcomes were different. But most importantly, as Luciano Gattinoni pointed out, what counts is the opinion of the experts. And Gattinoni wrote, when went to expert panels, sharing 33% of participants and the same evidence, which is, as we have seen, is not completely true, reach different conclusions, it suggests that opinion outweighed evidence. So in conclusion, first of all, I invite you to read the recommendations, not sticking to the bold part of it, but just reading through the manuscript and the justification of the recommendations. It's clearly very difficult to issue blanket recommendations that apply to the entire population of patients with ARDS, which is, as we know, a syndrome with a high heterogeneity. It's very important to individualize patient care, and this was shared it's a common opinion. And of course, as I pointed out also before, I strongly think that we need collaboration and joint efforts from the scientific societies to develop synergistic clinical practice guidelines. Thank you very much for your attention.
Thank you very much, Giacomo, for this really clear presentation for the 2 guidelines. It's a question over there. Thank you. Could we get a microphone is coming, so thank you. No, please do use the microphone.
Yeah, it is.
So thank you very much. I missed that because I had to attend a call. And then about corticosteroids, according to the two guidelines. So, and my question is a comment. I know that there are guidelines published in Critical Care about corticosteroids in critical ill patients, but I didn't like it a lot, that manuscript. Then my suggestion is, since this is a therapeutic approach that decreases mortality in some, and ARDS, community-acquired pneumonia, and sepsis share many of the, let's say, phenotypes, or I don't know, endotypes, or whatever. Is there a need to clarify this? Since this is a therapeutic strategy, cheap, and a therapeutic strategy that saves lives and decreases mortality, what do you think?
Well, I think that, first of all, we did, as I said, we did not study corticosteroids in our guidelines, so only the ATS, and the ATS were in favor of it. And I think that the manuscript you are referring to is a sort of consensus guidance that was published in Intensive Care Medicine that indeed recommended ARDS in patients, as corticosteroids in patients with ARDS. I think personally, and Lieuwe Bos may probably comment on this. I mean, ARDS is an inflammatory disease, so it makes a lot of sense to give anti-inflammatory drugs. But still, there are different profiles of inflammation. As you pointed out, we are stick with the syndromic definition of diseases, better, of let's say, nosological definition of syndromes, but syndromes are clinical constructs. And many patients with sepsis have ARDS, so they overlap. So we end up with a very heterogeneous population. In my personal opinion, and this is also for COVID-19, we gave steroids to every patient with COVID-19, but I think that we should look better into the profile of the immune response, the inflammatory response, to find if there are these now famous treatable traits, and there will be probably a subpopulation of patients, those who are more inflamed, who will benefit from corticosteroids, while there are probably others who don't. We're not there yet, but I don't think that the answer would be to give corticosteroids to everyone. I think it should be that we should select those patients who will benefit from corticosteroids.
Quick.
In this paper from Dutch group and several individual data analysis, the only predictor of that the corticoids will work was a CRP level higher than 20.
That's right.
So I think that we are in that direction.
Thank you very much.
Thank you.
We've got a question over here.
Very quick. My criticism to this new definition is that you lost a fantastic opportunity to include some biological information in the definition. Why you are not including this?
Yeah, well, actually these were like guidelines in the first domain of our guidelines, and the second one, which was called phenotyping. We recognized the importance of incorporating into the definition and into the assessment of patients with ARDS, also the study of inflammatory biomarkers and those processes. So our guidelines were not intended to do that, but for sure we were in favor of let's say, renovating the definition, trying to incorporate also biomarkers or markers of molecular pathways that can identify subsets of patients who have different outcomes and a sort of heterogeneity of treatment response.
Thank you very much, Giacomo. Thank you. And now it's my pleasure to welcome to the podium Dr. Paul Mayo from New York, United States, who is going to answer a very interesting question. Does this patient have hemodynamic pulmonary edema or ARDS? Thank you.
All of you are tortured by standard chest films in the ICU that are rotated, under or over-penetrated. They're supine films, AP, and they give you a summation artifact of a complex three-dimensional structure that's squished down to 2 dimensions. And they're always delayed in your accessing the test. Sometimes in my busy ICU for an hour or two, the patient is dead before the x-ray is done. And fraught with confirmation bias. We know what we're looking for, so we see it. False positive, false negatives. And is there an alternative? We agree that CT scan may have very occasional application in the critically ill, but I would propose that lung ultrasonography is far superior to chest films and in many ways has operational characteristics as does chest CT, except it's in your hand for rapid assessment of respiratory failure at point of care. It's always best combined with echo, and I would regard it as an essential skill for the frontline intensivist, as in the go-to modality for ICU chest imaging. So there's a common problem in the ICU. I'm going to see it on Monday. I'm a PGY 46, but I still do 14 hard weeks a year in the unit, and this is what I'm going to see. Bilateral opacity pattern that fulfills criteria, let's say, for the sake of argument, for this thing called ARDS, but always in the back of everyone's mind is there a contribution from cardiogenic pulmonary edema, which is treated rather differently than ARDS. Might lung ultrasound be helpful? So I'm going to assume that everyone, or most people in the room, have some knowledge of lung ultrasound, and every one of those present know what a beeline is. Those are vertical in orientation. They reach the bottom of the screen. They move the pleural surface when the pleural surface moves, et cetera, et cetera, et cetera. And they represent what we would say interstitial abnormality of some sort. Cardiogenic pulmonary CPE beelines, they're caused most probably by distension of interlobular venules that go right out to the periphery of the lung, right out to the visceral pleural surface, and as soon as left atrial pressure is elevated, they distend virtually instantaneously when that left atrial pressure is sufficient to distend them. They can come and go very quickly with treatment, even during stress echo. However, beelines that derive from ARDS or primary lung injury, they're caused by inflammation, edema, alveolar fluid collection at the very periphery of the lung in the interlobular septae and the alveolar compartment. And perhaps we could distinguish one entity, cardiogenic pulmonary edema, from primary lung injury with ultrasound. Let's think about that. And it turns out that pleural morphology may allow us to make this differentiation. You have to do this with a linear high-frequency probe, lacking penetration, but great resolution. You can use your longitudinal or off-axis transverse plane scanning. And generally speaking, with CHF beelines, the pleural surface is smooth and thin, whereas if you identify an irregular, fragmented, or thickened ARDS pattern, that is very suggestive of primary lung injury. There's debate as to whether you use a line approach to scanning or a 12-zone approach. That's another discussion. There's also whether we should start doing formal aeration scores. And these are the two key articles to convince you. The Copetti and Copetti, I think they're son and father, but I'm not sure. Back in the early 2000s, they were the first group to describe that pleural morphologic changes were characteristic of ARDS and less common in patients with CHF. They also determined that a reduction of lung sliding might also be relevant, all right? And also patchy distribution of B lines was consistent with primary lung injury. And I think a lot of us read this article and we liked it, and it sort of faded away, and we sort of knew about this somewhat. Very interesting article, but this is the article that everyone in the audience must read. It's the key article, number 2, and it comes out of the Amsterdam group, who are now the leaders in lung ultrasonography in the world, in my opinion. And they did a very nice study, published in a credible journal, where they were able to distinguish non-cardiogenic interstitial syndrome from cardiogenic pulmonary edema quite well. No test is perfect. And I quote there that you see sensitivity and specificity, 94 and 89%, no test is perfect, for distinguishing between the two entities. They had a validation cohort that was pretty good. Read the article, and I don't have time to give you more detail about it, except to say this is what you're looking for. Up top are frozen images from the article, and you can see the fragmentation, the thickening, the irregularity, and the relative smoothness that distinguishes the two entities. Here I have some real-time images for my unit. And on the left, you have a lot of B lines with a smooth pleural surface. I should have used a vascular probe, but this was convincing to us. Whereas on the right hand, you have this thickened, irregular, fragmented surface, which was a ARDS primary lung injury patient. Clinical correlation is always required. What I tell my fellows, there's one cause of smooth pleural line with B lines, and that's CHF. There are 873 causes of irregular pleural surface, one of which is ARDS. And the other 872 are all those other diseases that have names, but the interstitial lung diseases, lymphangitic carcinoma does it, occupational exposures of a variety cause lung injury. It goes on and on and on. So take care. Always understand whether it's really ARDS or is it a pre-existing cause for the irregularity, or both, even worse. And then lurking is the combined entity of a CHF pattern with ARDS, older patients with AS and bad LV who have ARDS injury pattern. So in both cases, I'd always recommend that you use echocardiography to get an estimate of left atrial pressure and diastolic function. That's always combined with lung ultrasonography in order to look for that twofer, a double diagnosis. The summary, therefore, is in general, I would say thoracic ultrasonography really must be the primary imaging modality, which occasionally has to be supplemented with CAT scan. In my unit, we just don't do chest films very much any longer. As a warning, lung ultrasonography requires the clinician to actually go into the room and push the patient around. No armchair intensivists. They're not interested in this. You have to engage with your patient physically to do this. If B lines are the primary finding given the right clinical presentation, always evaluate pleural morphology, and if it's abnormal, ARDS or primary lung injury of some sort is the primary thought. If it's a normal pleural morphology with bilateral distribution of B lines, you can find the scoring in that article. It's very probable to be ARDS, but always keep in mind the possibility of two coexisting mechanisms, and therefore echocardiography with Doppler analysis becomes required. That's it. Did I finish on time? Yeah. Are there any questions here?
Thank you very much, Paul. Yeah, you're right on time, and we do have time for one or two questions, if there are any.
Are any of the Dutch group here?
Yes, Dr. Bos is in the
There you are. Okay. Stand up. There's the man. Okay. And is your co-conspirator Dr. Smits here? Oh, I'm sorry. Yeah. So anyway, read their stuff, because it's not just about CHF and ARDS. They have some great stuff about pneumonia and things like that. Okay. So, questions? Good. All right.
Thank you very much.
Thank you.
Okay, well, it's a great segue. I'm pleased to introduce our next speaker, who by coincidence is Dr. Lieuwe Bos from the Academic Medical Center in Amsterdam, and he's going to talk to us about lung morphology-guided mechanical ventilation.
Yeah, so it's slightly uncomfortable to come up here right now, but I'm happy to present to you our work on lung morphology-guided mechanical ventilation. Before doing so, I have to disclose one thing. It's an intellectual disclosure that I am the co-PI of a trial investigating this subject. So I am very enthusiastic about this, and I hope to bring over some of this enthusiasm to you. And I also have to disclose that I'm from Amsterdam, so I really like lung ultrasound, so I might talk about that a bit in this presentation as well. Before going into the trial, I think we heard already in the first few presentations that phenotyping is the new hot term in ARDS. And I would like to spend a few minutes on why it's not really new, why it's not really something we should aspire to, but should actually be doing, and why not doing it has led us down a path of negative findings. So this was the year 1975. My parents just met. It was more than 10 years before I was to be born. And in that year, we were already talking about lumping and splitting in the literature with almost the same words as we do now, just not mentioning the word phenotyping, but calling it splitting. And I strongly recommend you to read these two short editorials in the Blue Journal at the time. So if we look at clinical trials that have been done in ARDS, we have mostly used no enrichment strategy. So let's get the numbers up, get every patient that potentially fulfills ARDS criteria, get them into a study. And this is very good for generalizability, of course, but we know it will give negative results in trials. Prognostic enrichment has some more advantages, and I think we have seen successes with the use of prone positioning in patients with a low PF ratio and the use of ECMO in patients with severe hypoxemia, because the risks of the intervention outweigh are mitigated by the benefit of the intervention. You can take more risk in a patient where the baseline mortality is higher to reduce that outcome. But I think I wanted to speak to you about predictive enrichment, which means knowing beforehand this patient is more likely to respond to my intervention, not because they are more severely ill, but because they have features that actually predict the physiological response or the biological response that I'm targeting. And I think this is the future of what we're doing. But when we say we have to personalize ARDS care, we're not talking about anything in particular, and there are many ways to do this. So in this talk, I will just focus on one item called lung morphology and not discuss any of the other parts that you can hear in other talks from other presenters. So when we talk about lung morphology, we typically split the patients into focal and non-focal lung morphology. This is also not new. In 2000, J.J. Ruby described these patterns based on the European CT study, where 100 CTs of patients with ARDS were performed, and based on characterization by radiologists, by intensivists, they found different patterns. And one of those patterns had consolidations in the dorso-inferior fields of the lung, you see on the left, and those patients were very difficult to open the lungs. They did respond to prone positioning. So in the prone positioning, these fields would be anterior all of a sudden, and it would be much easier to evacuate mucus from these areas and to open these areas. The non-focal lung morphology, on the other hand, was recruitable, as we know from most of the traditional ARDS models, for example. Then it was silent for some years, and then the Jean-Michel Constantin and his group in France did a live study. I think one of the most revolutionary studies in our field, because they had the guts to go and randomize patients based on a phenotype. So in the control group, everyone got guideline-based mechanical ventilation, but in the intervention group, the mechanical ventilation strategy depended on the phenotype of the patient. Focal patients got a low PEEP strategy with mandatory prone positioning, irrespective of the baseline PF ratio, while non-focal patients got an open lung strategy, reaching plateau pressures of 30 centimeters of water. And prone positioning was only used as a rescue therapy. In the intention to treat analysis published in The Lancet about 5 years ago, there was no difference between these two groups. So should we stop doing it? Well, they noticed that there was a difference in 40 patients, in about 20% of the patients in the intervention arm, between the allocation given in the center where the patient was randomized and the evaluation of the images in the central unit, where they had much more experience judging whether a patient had non-focal or focal lung morphology. And this was driven by the fact that they, in the beginning, wanted every patient to receive a CT scan. But this, of course, didn't happen for reasons mentioned by Paul before. So they did chest X-rays in about 80% of these patients. If they then looked further into this personalized group, and they compared the misclassified patients to the classified to the correctly classified patients on the right side with the dotted lines and the solid lines, and they also compared the misclassified to the correctly classified patients in the control group, you notice that these misclassified patients were only harmed when they were randomized to the intervention arm. Of course, because they received the wrong treatment, they were killing these patients, basically. So this is a central point to take away. Every time you are personalizing at the bedside and you're taking the wrong strategy, you're misclassifying the patients, you're probably harming them. And this might be why a general approach, giving everyone the same intervention, is working well in general. And it's very hard to prove that something is better than that. So I'm going to hate on the chest X-ray for just one slide. Normally I take a bit more time for this, but Paul already did a good job. So we already knew that the chest X-ray is really, really bad in identifying this focal versus diffuse ARDS. So in the same study, in the same series as the original description of these focal and non-focal lung morphologies, the authors already showed that there's really no way to do that based on a chest X-ray alone. So we identified lung morphology based on lung ultrasound, and we were able to develop, using the databases that we had, a classification method that was very, very accurate compared to the chest CT, and is basically is built on the anterior lung ultrasound score. So you scan 4 fields. If there are no abnormalities, this is probably focal. If there are abnormalities, this is probably non-focal. And this we implemented in the Pegasus trial, where we took the same approach, so the same interventions as the live study, but now using lung ultrasound rather than the chest X-ray to identify the morphology of the patient. And I'm able to show you not the results of the trial, because the trial is still ongoing, but I can show you the first interim analysis, the phase 2 part of the study of the first 80 patients, because we were very, very concerned about this misclassification and misalignment of treatment. So here you see that 44 patients got randomized to the control group and 36 to the personalized ventilation group. Patients in this trial are typical of any ARDS trial, so 60 years of age, mostly male, slightly frail. 4 hours after the diagnosis of ARDS, patients were randomized within 1 day of mechanical ventilation, and most of them had pneumonia with a PF ratio of about 110. So quite severe population. If we then look at the classification between the local research team and the expert panel, we got back to this 90% accuracy that we identified in the previous studies as well. What we also found is in those patients where we were not agreeing with the local team, the 3 investigators in Amsterdam, who all reviewed thousands of lung ultrasounds, were also disagreeing with each other. So this was the point where it was not clear whether it was 2 areas that were just B1, just had enough abnormalities to classify it as that, or it was just still classified as an A pattern. So it was borderline. And probably every time you do a study with phenotypes, you're going to get these borderline results, and it might be important what you do with them. So we're investigating this further and trying to get CT scans on these patients, see how their response to the intervention is in terms of physiology, because of course we cannot look at the primary endpoint of the study as we are blinded to that. Then could we deliver this intervention? Because when we were talking to centers, some centers would say, you cannot give 5 PEEP to an ARDS patient, they will die. Some centers would say, you cannot do an open lung approach anymore. Well, actually, in this study, we were able to get down to these low PEEPs in most of the focal personalized patients, and we were able to use these high PEEPs within the limits of safety that were set in the protocol in the patients who are non-focal and got the personalized intervention. You also see that the control arm has a nice spread with a PEEP around 10, which is similar to the PEEP set in most studies. So to conclude, you can split the population into focal versus non-focal lung morphology, but lung ultrasound is a lot better than chest X-ray when doing it. I think we need to be mindful that these misclassifications are very, very harmful. And anyone taking this home with them should be mindful of them, that you could be hurting any patients when implementing personalized approaches without doing the science first. And that's why I think these prospective subphenotype-informed randomized control trials are essential. And I hope to provide a small contribution with Pegasus, where you have now randomized 140 patients in 11 countries. So if you are interested to join, you can still reach out. We have a fantastic group of collaborators who are pushing this study every day. Some of them are in the audience today. And I think this is the way we can move this field forward, not by doing unselective studies, but trying to really invest into this kind of personalized or precision medicine trials. Thank you very much.
Thank you very much for this great talk, and congratulations, and hope the trial goes well. Any questions? Oh, there is one over there and one at the front. And if you, yeah.
We have a lot of success with the morbidly obese patient is very hard to scan. You mentioned that. We have a lot of success with transesophageal lung ultrasound. You get fantastic images of the posterior thorax, and that prevents need for CT transport, which is very challenging. Do you do that in your practice at this point? No.
No. So it might be because we don't have as many morbidly obese patients as you might be used to.
I noticed this. Yes.
So I have not found the need for that.
Just
I love it how you're pushing the field forward that way.
Right.
Thank you. There is a question at the front, and then we might.
Thank you very much for your nice talk, and thank you for the Pegasus study. But I have a question that I don't know if this has been done or not. Is there any study in big animals with confirmed ARDS that validates echography compared to histopathology of the lung? Because this is needed. Yeah. This is needed, to my knowledge, no.
So ultrasound has been validated with CT as the gold standard, but not with histopathology in that way. We're currently working with collaborators in Dresden on developing a pig model for focal versus non-focal lung morphology with PET images, which is really challenging actually, because most models, infectious models are very uncontrollable. Mechanical ventilation models give just injury everywhere. So it's actually quite difficult to replicate what we see in patients in animals. But I think you're right. There is a lot more work needed in that space to get a better sense of what we're actually measuring.
Thank you. Last question, Francesca.
Thank you very much. Great talk. I've just one doubt, and perhaps it is a provocative question. So one side, we have seen some doubts on the guidelines, how much the PEEP level, and so on. But on the other side, we should be very precise with the phenotype. So in your opinion, how would you combine these 2 points? Thank you.
So that's a really essential question, because the guidelines rely on studies done in unselected patients. Slight differences in the distribution of the patients going into the studies can give huge differences in the outcomes of the studies. So, and we're still treating as if these were the same patient populations. And I would really recommend everyone to read the individual patient data analysis that Professor Torres referred to on corticosteroids and CRP as a predictor. I think this is the way forward that we should take. We should start looking not only at the whole trial, like what did the trial do, but how did the patients in the trial respond to the treatment, and what were their individual characteristics, rather than just the whole trial population. But that means that we have to do trials differently, because we need to capture all of these things. And it's pure poverty that now we have all of these trials in pneumonia, all of these trials in ARDS, and the only thing we have in terms of a biological signal is CRP, which is, not the most elegant way to divide that.
Fantastic. Well, thank you so much once again. Thank you. And now it's my pleasure to welcome Professor Manu Shankar from Edinburgh, UK. He's going to give us a talk on respiratory failure with lymphopenia, a new syndrome. Question mark. Okay.
Thank you very much, Luigi, for the kind introduction. I've already messed up by moving my slides. Just a brief acknowledgement to my funders. I'm funded mostly through UK-based research charities, and I do have intellectual conflict to declare. I run a precision medicine program called TRAITS, so some of what I'm going to talk about is what we are doing in TRAITS. And then I'm also chief investigator for corticosteroids in ARDS, which is an effectiveness trial of what DEXA-ARDS did in a different population in the UK. And we are doing some biology, but not as sophisticated biology as you heard from Lieuwe with ultrasound. All of the advisory board activities are managed as institutional funds, so I don't have any conflicts to declare. So here we go. So I think I'm going to go through a reason why I am proposing a very different trait, sandwiched between 2 ARDS researchers. Marco Ranieri is next, and we've got Lieuwe Bos at the front. So I'm not an ARDS researcher, I'm going to propose something different. That's going to go down well later. So why am I doing this? So first, 2 points I want to make here. Multi-causality, and the second is the immunomodulation trials in ICU syndromes have largely failed. That includes ARDS. So as critical care physicians and trialists and researchers, we have this kind of what I called as the received view of causality. Everything is fairly old-fashioned. An effect follows a cause, like an infection results in ARDS or sepsis, and then, but not always, we know that, because quite a lot of the ward patients don't have any of these syndromes. then you got this idea of non-reflexive and transitive principles that we just adopt without thinking. And we also managed to then ignore some fundamentals of causality. Critical illness is not a single gene mutation, it's a complex disease. We kind of almost always forget that. And then we don't have good surrogate endpoints, yet we look for surrogate endpoints to either diagnose and or treat or look for treatment response. And then always kind of end up with this subphenotyping idea, which may not be the only solution. Those are the reasons why I think talking about this is useful. So what do I mean by multicausality? Every syndrome, whether it be sepsis, ARDS, kidney injury, whatever, has got some modifiable and non-modifiable cause. What's a non-modifiable cause? Example, age. If you have underlying comorbidity, and a modifiable cause, some of it is attributable to the disease, some aren't. And therefore, when you test a treatment that is following a particular pathway, some of these attributable mechanisms are managed and some non-attributable mechanisms. And when I say we don't have any surrogates, people kind of say, but we do. Let me give you a very good example of what a surrogate is in the context of heart disease. So I'm just going to use coronary artery disease. There is no doubt as to what a surrogate is. If you got myocardial infarction and you got a thrombosed coronary artery and you open the thrombosed coronary artery, you save muscle. There is no better surrogate than the TIMI3 blood flow on a coronary artery. And some of you may remember this was Retiplase, Rapid 2 phase 2b trial of Retiplase versus Alteplase concluded that Retiplase is better. Then comes the efficacy trial where Retiplase increased mortality. And then somebody had the thoughtful kind of process of going back to Rapid 2 trial and say, what did we do there? Why did we not actually improve the surrogate we thought we would improve? And that's because you got a very different reopening of the coronary artery at 30 minutes. So even with a beautifully simple surrogate like MI and coronary artery disease, you have problems. And it'll be foolish for us to think that we have found a surrogate. So last kind of point about the clinical trial paradigm. Currently, you do sepsis and ARDS, you do the intervention or usual care, and then you do a follow-up, and then often you don't see an overall treatment effect, and then look for either a subgroup effect or HTE, and then we kind of do this all over again. So over the last 15 years or so, people would have started doing a trial and then gone back to more refined eligibility criteria or subtype to do a different trial. So we are in a slight limbo, but we are moving gradually forward to something closer to the utopia that Lieuwe kind of concluded his talk with. So in that context, let me introduce the idea of treatable traits. This is borrowed from cancer and asthma. It is not my own creation. It's got three broad principles, which is you have an abnormality that is associated with an outcome. So in a way, you're wrapping around the biological mechanism and the surrogate into that one statement. It is measurable at the bedside, like the ultrasound or whatever else that I'm going to talk about. And then there are some treatments that exist for that biology. And I said this comes from cancer. So here you got HER2 mutation in breast cancer. It has transformed breast cancer outcomes. And you got a very simple lab test, and you got a drug, monoclonal antibody that targets that. And in a much more disease that is closer to our field, which is asthma, you got type 2 asthma. The original description was in 2006 from Sally Wenzel, and then by 2018 or 19, we've got this T2 high asthma and managing those asthma with monoclonal antibodies and specific therapeutics. So it is possible that you can use the biology to get to this point, provided we accept that it's multicausality. Okay, and the next thing I want to kind of bring to you is this notion of syndrome-agnostic critical illness biology and treatable trait. What do I mean by syndrome-agnostic? If you think about immunology, it's fairly simple at the start. You have a pattern recognition or an effector response recognition to the insult. And then you cause your critical illness, which is you either have a tissue damage, like the lung epithelial damage, or you have a shift in the homeostatic set point. In other words, you got inflammation. But if you track back, all of this can be kind of wrapped around very simple biological features, which is you got an inflammatory stimulus that actually results in a common pathway, both effector mechanisms and refeed mechanisms. And the inflammatory pathway is initiated by infection, injury, or stress. ARDS could be caused by community-acquired pneumonia, pancreatitis, trauma. So that's a kind of framing of the respiratory failure part that I'm making with this statement. And then if you take a disease like pneumonia, you essentially have a microbial threat that is sensed by various mechanisms, pattern recognition receptors and other mechanistic intracellular mechanisms, and then you have the effector pathways resulting in altered tissue homeostasis, inflammation, and exudation in the lung. And that's where I bring in this idea of lymphopenia and respiratory failure trait. Nobody in this audience would shout at me if I say respiratory failure is associated with increased risk of death. More severe the disease, greater the risk. Lymphopenia that persists beyond 3 days is associated with greater risk of dying. That is fact, that's published, and that's got a causal mechanism. And lymphopenia and respiratory failure are caused by things like sepsis, ARDS, pancreatitis, and other things. Both are measurable with a routine test. And the more important than that, there are some key molecular mechanisms that tell us a target. So let me just take you through the lymphopenia mechanisms that might be of relevance, and it's shared across different diseases. You've got only 5 things that could go wrong with the lymphopenia as the etiology. So you have either a cellular death in the form of apoptosis, pyroptosis, or autophagy, or the lymphocyte is trafficked out of the peripheral circulation, or there is impaired lymphopoiesis. One of the 3 things, or combination of all 3, which is the more likely. And then, if you think about respiratory failure, I don't need to kind of highlight the biological mechanisms that results in ARDS, because that's well understood in this audience. So I'm just going to kind of say, trust me, the combination provides you with a different information to what you get from either of those 2 things. And it, more importantly, provides some prognostic and predictive enrichment, which we heard a lot, without doing ultrasound or complex classifier models. And I'm just going to last few minutes talk through the work by one of the PhD students in the group, again a Dutch person in the group who is doing a PhD on Precision Medicine. And Renske proposed this idea that actually, if you take lymphopenia and respiratory failure trait, I can tell you that it is syndrome agnostic, it has got some fundamental biology, and it gets you treatment. So let's kind of take you through some examples. We've taken some blood samples from patients with pneumonia, and we also have control samples with sterile injury in the form of cardiac surgery. And we did a whole host of biology on it, and I'm going to show you some very simple results to just get my message across. So the first thing that we did was to look at the cytokine profile. On your left is the lymphopenia and respiratory failure trait versus healthy patients. And as you can see, in lymphopenia and respiratory failure, you see a profound change in the biological pathways that you would expect to see, like IL-6, IL-10, CXCL8, etc. And then on the right-hand side, what Renske has done is to say, if you have an infection-related infection-related lymphopenia and respiratory failure trait, in other words, community-acquired pneumonia or sepsis, and on the right-hand side, somebody following cardiac surgery or pancreatitis have a lymphopenia and respiratory failure trait, are they at a cytokine level very different? And you can see the only difference that we could find is on CCL4. There is no other difference between those 2 syndromes. And then what Renske did was to give you an example of the cytokine profile overall, but what we then did was to figure out the mechanistic kind of linkage between these biomarkers. And what you see here is a very simple network plot. In a healthy person, you have an immunology network, which is what you would expect to see. And then what happens in the context of lymphopenia and respiratory failure across different syndromes, you see a very, very different pattern that focuses in on, there is IL-6 and IL-8 kind of linked very closely together because of neutrophil-driven inflammation or innate immune inflammation. And there is biology that is fundamentally related to the adaptive immune system that's in the bottom part of the network. So the top part is the inflammation and the bottom part is the adaptive immune network primarily. Then what Renske did was to look at the transcriptome differences in patients with lymphopenia and respiratory failure versus healthy transcriptome. You see here approximately 3,000 odd genes completely changing. And then Rensky asked the same question, which is, what happens if it is sterile inflammation versus infection-related inflammation? As you see, there are some differences, but it is nowhere close to what you see with the overall syndrome. In other words, the lymphopenia with respiratory failure due to infection or due to sterile insult kind of are biologically quite close by at that early time point. And then what we did was to figure out the pathways, and I want to kind of just focus in on the top pathway purely for in the interest of time. And there what you see here is the IL-6 JAK-STAT pathway being the primary kind of mechanism that is most enriched with these transcriptome differences between the two, sterile inflammation versus infection-related inflammation. And as you know, JAK-STAT pathway is involved in cytokine production. You kind of activation of a JAK-STAT pathway will result in IL-6, IL-8, TNF, and that is associated with what people have described as hyperinflammation. And then if I kind of take away the kind of baricitinib, to explain the baricitinib biology, you can see that if you give baricitinib, you get increase in lymphocyte count, increase in IgG, and there is a suppression of the STAT3 pathway and cytokines and attenuation of inflammation, which we saw during COVID with the various trials. So that's how we kind of took from a simple end-of-bed clinical trait to a potential biological response with treatment. So to kind of summarize, current ICU syndromes need refinement, and proposing a very, very simple borrowed conceptual model from cancer and asthma on what is called a treatable trait. And I'm proposing lymphopenia and respiratory failure as a distinct entity which might actually get us to a slightly different path towards improving patient outcome rather than complex biology. Thank you very much.
Thank you very much, Manu. In the interest of time, we're going to need to vacate the stage in 3 minutes, so I'd encourage anybody with questions for Professor Shankar to find him after the session. I'd like to thank all of the speakers for their excellent talks. In case you're wondering, we knew Massimo Antonelli was not going to be here today, so we've allowed some extra discussion in between the talks. Thanks to you for your participation, and thanks to my co-chair, Fujii.
Yeah, thank you very much.
Yep.